My name is Jason Lake. I'm a orthopedic surgeon doing primarily foot and ankle in my practice, and I was asked to give this talk by an orthopedic surgeon who's not a foot and ankle provider, who basically said, a lot of times someone will curbside me at the end of their visit for their knee or their hip and ask me about their foot. And they just wanted a little bit more information on what's new for some of these basic problems that may or may not need referred out. And so this was meant to be a refresher for the non-foot and ankle provider, or possibly even a primary care. So it's not going to be high level surgical correction, decision making, more stuff you'd see in the office commonly. I have no disclosures related to this topic, and let's get into it. So one of the things that are very common in foot and ankle is a typical ankle sprain, and you can get ankle sprains doing all kinds of basic stuff, and there's different grades to ankle sprains. Most of us know that there's 3 grades essentially, ranging from mild, which probably never end up seeing a physician. This is where someone tweaks their ankle and it may swell briefly, and in a few days they're usually feeling better. Someone who has a grade 2 or moderate sprain probably has a partial tear and may require an x-ray depending on their exam. And those who have a complete tear or a grade 3 injury are often unable to bear weight. And something like this, they may not really curbside you in the office. They may have already been to an urgent care or seen someone, but who knows? Sometimes people will walk it off and give it a few days and then know they have an appointment coming up and want to run it by the provider so they don't have to pay for an extra visit in the ER or the urgent care. So when someone says they sprained their ankle, when do you need to get an x-ray? Well, I think it depends. What we look for is the classic Ottawa criteria. And so if someone's tender along the posterior aspect of the medial malleolus, if they're tender along the posterior aspect of the lateral malleolus, or if they're completely unable to bear weight, either at the time of injury or when you examine them, it's probably worth getting an x-ray to rule out other associated issues. The reason that we look for tenderness on the posterior aspect of the malleoli are that the superficial deltoid and then the anterior talofibular ligament are on the front half of the malleoli. So if you just have a sprain, of course you're going to be tender anteriorly. And so the ones that are tender more posterior are going to be ones that you worry more likely about a fracture. Sometimes it's important to include a foot x-ray as well. Sometimes an inversion injury to the ankle results in a foot fracture as opposed to an ankle fracture, or can result in an ankle sprain. But also there's a foot fracture as well that gets missed. This is just an oblique of the foot, and you'll see there's a small anterior process calcaneus fracture. And these are not common, but not uncommon, but they can be hard to see on an x-ray. So for someone who's tender, kind of in the hind foot, more distal than the ankle, this is something that you have to watch for. And if you're not looking for it, then you'll miss them. And one time someone told me that they've been working for 20 years and they've never seen an anterior process calcaneus fracture. And I said, well, they've been seeing you, even though you haven't been seeing them. Thankfully, they usually do well non-operative. So it's not a huge deal, but it's something to note. On this x-ray, there's a small os perineum too. And so this can be confused with an avulsion fracture off the cuboid or the 5th metatarsal base, but it's something to watch for as well. I like in our practice to get weight-bearing x-rays if possible. Much better to see the alignment. Sometimes in foot x-rays, just like in knee x-rays, the alignment or the joint space looks one way when they're lying down, and it looks totally different when they're bearing weight. Initial treatment for an ankle sprain. So immobilization early on, and that depends on the grade. So for a grade 1, you don't have to do a lot. For a grade 2, sometimes people do better if they're in an ankle brace or a boot or at least an ACE wrap. Icing is interesting. I put on my slide only if you use a flip phone, meaning Most people don't use a flip phone at this point. It's old school. And initial training that most of us receive is the whole RICE, where you rest it and you do ice and compression and elevation. And in reality, most of the professional teams now are not icing immediately after an injury. They're treating them a little bit differently. They're still elevating. They're doing a light compression. And for an ankle sprain, I think it's important to do gentle range of motion, and then crutches as needed. The important thing is that early on, we don't do maximum plantar flexion inversion. So you want to tell your patients not to plantar flex and invert or recreate the mechanism that was there when they sprained their ankle. If you do that, what you worry about is over lengthening the ATF as it heals. Ankle sprains typically heal. The question is whether or not they heal with residual instability. And those are ones that may require surgery in the future. So when we get to the next slide and talk about rehab, with grade 3s, we have to be a little bit careful. So return to play or rehab after an ankle sprain, the goals early on are to reduce the swelling, because if we can get the swelling down, it helps with pain. We want to work on early range of motion with the exception of maximum plantar flexion inversion. Then we work on strengthening, and as they go through their functional rehab, it's important that you don't just do bands on your ankle and that's it. There's a lot more that goes into stability of the lower extremity, and that includes core strength, glute work, a lot of single leg work. And then as you kind of get through that, then they start to work on more sport specific or whatever goals the patient has, we start to work on those specific things. So again, grade 1, you can get through all your functional rehab, which you do on your own, typically in a couple days. Grade 2 may or may not end up with a physical therapist, and some of the functional rehab can be done on your own, depending on, is it a grade 2 minus or a grade 2 plus. Grade 3 or complete ligament injuries take longer. These may take a month or 2 to get better. The other thing about grade 3s is there's some evidence that maybe immobilizing them early on for the first couple of weeks to limit plantar flexion inversion may reduce the chances of them developing chronic instability. And these are hard because there's a little bit of an art to it on exam in checking their stability of their ankle with an anterior drawer and talar tilt. And so anyone that feels unstable on exam, we take it a little bit slower with them than a grade 3 that's nice and stable. Moving on to lesser toe fractures. So this is something that also doesn't always end up in foot and ankle specialist office. You know, someone stubs their toe on a dresser or the corner of a wall, and they may see primary care or, again, another provider, urgent care, or one of their other orthopedic surgeons if they're there for a shoulder or something else, and they may just ask, do I need to do anything for my bruised toe? And lesser toe fractures usually are fairly simple. Most of the time, we can buddy tape them. And so when we buddy tape a lesser toe fracture, we always do it to the toe opposite of the deformity. So in this case, the small toes has a proximal phalanx fracture and it's angled away from the fourth toe. So if you're going to buddy tape this, you would tape it to the fourth toe. And a lot of times these will slowly improve alignment over time if you buddy tape them, because they're usually loose enough where they'll do that. If it's one of the more central toes, it may be angled one way or the other, and you just have to choose the right toe to buddy tape it to. Usually a post-operative shoe is enough, or a flip-flop. Most patients are fairly comfortable, but the toes can swell for months. Surgery is rare for lesser toe fractures. This is typically reserved for someone who has a severe rotational abnormality that we think is going to be symptomatic in the future, or is significantly shortened or angulated. And sometimes what will happen is someone will stub their toe and the toe will cross over or rotate over the other toe. And so that can be a problem in the future. And so if it's something that you think is going to need to be addressed, sometimes it's easier to address it at the time of injury, so they only have one recovery, as opposed to recovering from a broken toe and then recovering from an osteotomy or hammer toe correction at a later date. Also, if someone's diabetic or has neuropathy, We also want to really watch their toe alignment as well, because if it rubs on the second toe, they may develop an ulcer. But for the most part, you can get away with non-surgical treatment for lesser toe fractures. If there's surgery, typically K-wires or suffice, something that goes in and comes out, so you don't have permanent implants, but once in a while, a screw can be used. So if someone stubs their toe and it's not one of their lesser toes and it's their great toe, treatment's very similar. Again, mostly non-operative. The only difference would be you may want to order, instead of just a post-operative shoe, because you use the great toe more when you propel forward, often a short walking boot is more comfortable for the patient. Not that either of them really immobilize the great toe, but it's usually more comfortable because it has more of a rocker bottom, and it limits ankle plantar flexion and dorsiflexion more than just a surgical shoe. Again, as long as they're not grossly displaced, great toe fractures can be treated non-operative as well. It's harder to buddy tape the great toe to the second toe. You can also tape it or just use tape to make almost a splint or a dressing that can be helpful. Operative treatment for great toe fractures are reserved for, again, significant displacement, rotation, intra-articular fractures. I think we have a little lower threshold to fix great toe fractures than lesser toe fractures because the deformities are. So again, we're a little bit more aggressive on fixing great toe fractures. Usually fractures can be fixed with K-wires that are temporary and left for 4 to 6 weeks, depending on the patient's age and fracture stability. If possible, we like to avoid the hallux interphalangeal joint so they can do some range of motion of the toe, because the biggest issue with toe fractures is stiffness afterwards, and it doesn't do us a lot of good to have a great looking x-ray if the toe doesn't move. All right, so heel pain. This is also super common for foot and ankle, and is going to be commonly presented at a primary care office or a curbside visit or a nurse asks you at the hospital, but heel pain. And I think most people on the call here know that plantar fasciitis, while it is inflammation in the acute setting, as it goes on months and months and months, it's less inflammation and it's more of a chronic degeneration because the tissue of the plantar fascia is not as springy and stretchy as it used to be. And it starts to break down and it gets a improper healing process that starts going on in the fascia, microscopic tears, laying down the wrong type of tissue, little nerve endings get in there that cause pain because the tissue is not normal fascial tissue, and the plantar fascia gets thickened. But it's not usually after an injury. Once in a while, patients can actually rupture their plantar fascia like in athletes, but for the most part, it's degenerative. Very rarely do we see, if ever, plantar fasciitis in someone under age 18. Usually if someone has heel pain and they're under age 18, it's not plantar fasciitis. But as you get older, heavier patients who do prolonged standing, the plantar heel pain, this would be the most common, but not the only thing that can cause it. It's usually loosens up a little bit as they start to walk, but if they sit for a period of time, then it gets stiff, the tissue stiffens up, and their first few steps are the toughest, and then it typically loosens up, but then if they walk too much, then it starts to hurt again. On exam, you really want to look for plantar heel pain as opposed to posterior. You always want to check their gastroc muscle, so you want to check their ankle motion with their knee bent and their ankle motion with their knee flexed, because the gastroc muscle crosses the knee joint. Most patients, unless they have ankle pathology, most patients have good range of motion of the ankle with the knee bent. Unfortunately, we don't walk with our knees bent or stand with our knees bent. And so when you stand, your knee is straight. So if someone has a really tight gastroc, there's a lot more force across the Achilles going down into the calcaneus, and there's more force across the plantar fascia. And so we see more plantar fascia abnormalities in someone with a tight gastroc. So you always want to check that and document that It doesn't happen every time someone has plantar fasciitis or plantar fasciosis, but more common than not. The other thing is you want to squeeze the calcaneus from medial to lateral, and you want to rule out a stress fracture. In addition, you want to check the tarsal tunnel, look for more medial hindfoot pain, and make sure it's not neurologic. Typically for neurologic stuff, patients won't have direct tenderness directly plantar. So first line treatment for plantar fasciitis. So number one, we recommend no barefoot. When you're barefoot and you have a flare-up of plantar fasciitis, or you have chronic plantar fasciitis or plantar fasciosis, it puts more strain on the fascia. And so no barefoot. Usually we start off with non-custom inserts because they're cheaper. And unless the person has a really tough foot deformity or a really high arch where an over-the-counter insert won't fit them well, we usually start with non-custom. We're going to have patients stretch several times a day and do it with their knees straight. So you'll see in this picture, the stretch that's working here is the back leg. So the back leg has the knee in full extension. And so that allows them to really stretch the gastroc and isolate it. If you bend the knee, you're stretching more of the soleus or the Achilles itself. NSAIDs can be helpful. And I don't know that the NSAID necessarily cures it or makes it go away. But sometimes when patients start to stretch or massage the fascia, roll it on a golf ball, it actually gets a little more irritated. And I think the NSAIDs make them more comfortable and allow them to do more of the first line treatment, such as stretching and massage. Second line treatment, corticosteroid injections work really well. Again, in my opinion, I don't know that the injection actually cures it. At some point, I think the body fizzles out and starts to heal it, but corticosteroids make you feel a lot more comfortable during the process. A walking boot will occasionally be used. We'll send people to physical therapy for modalities such as A-stim, Graston technique, dry needling, and these can be effective. Platelet-rich plasma is gaining traction. There's some good literature to support it as being equal or better than cortisone shots. Unfortunately, it's not yet covered by insurance, but that's something that may come in the future, and it may be more common. Custom inserts are usually second-line treatment. And again, the goal of the custom insert would be to really offload the heel and really support the arch. And for a lot of patients, the over-the-counter inserts really they're not high enough and they don't really match the patient's arch. The higher the orthotic gets, the better it has to fit. And so that's where the custom comes in play. If we sold really high orthotics over the counter, it would be uncomfortable. And so most of the over-the-counter ones are not aggressive enough. Night splint can help with morning symptoms. Surgically, we don't do a lot of full plantar fascia releases or open surgeries anymore if we can help it. Sometimes just releasing their gastroc surgically can help. 10X is a newer procedure where you use high-frequency ultrasound to help debride or release the plantar fascia and almost create an injury to change the healing pathway, and that can be helpful. So the other source of heel pain would be posterior heel pain, and that's related to the Achilles. And it's the same process that goes on to some extent with Achilles tendinosis as there is for plantar fasciosis or plantar fasciitis. And in this case, again, the Achilles is getting stiffer as we age, less springy, more prone to degeneration. And so we see it in the same patient population over age 30, higher BMI, tight gastroc, diabetes, etc. Usually they feel better when they're sitting or resting unless there's pressure on the heel. And then when they first get up and walk, it's stiff, it hurts, it loosens up, and then it gets worse again with too much activity. And with Achilles tendinosis, it can be down at the insertion, and it can be associated with bony abnormalities such as a posterior spur or a Haglund's deformity, or it can be mid-substance. So you got to check both locations. But the main thing is you'll see swelling posteriorly, tight calf muscle, and pain posterior as opposed to pain plantar like there is for plantar fasciitis. And in reality, patients can have both at the same time. those patients almost always are tight. Treatment for Achilles tendinosis is similar to for plantar fasciitis. Same thing, no barefoot, stretching with the knee straight, anti-inflammatories. Night splint can help in some patients. Often with most insurances, in order to get it covered, you have to have plantar fasciitis as a diagnosis. So just something to be careful of, but very similar treatment. And remember, these conditions where you're having to overcome tightness and tendon changes, I always tell the patients that when you start stretching, it's not like you feel better in a day or two. It may take weeks or months for it to get better. Second line treatment for Achilles tendinosis, physical therapy, eccentric exercises can be helpful, A-stim, dry needling. There's some evidence that shockwave therapy may be beneficial, but may not be. And it can be difficult sometimes to find a location that does it, and often not covered by insurance. Walking boot can be helpful short term, just to make the patient more comfortable while the body heals, but we want to continue to do the stretching and the therapy along with the boot. Platelet-rich plasma, not yet approved, but shows some promise. In our practice, we found it better for mid-substance as opposed to insertional, because often insertional is associated with a bony abnormality. And then also the ultrasonic debridement 10x showing some promise as well. Surgical treatment is offered if patients don't improve with conservative treatment after 6 or 9 months. And it is effective, it just is a longer recovery. This picture is someone who's a revision Achilles surgery where we did a flexor hallucis longus tendon transfer. So you can see the Achilles, which has been debrided. It's very thin and unhealthy, and there's a healthy FHL tendon underneath. This is kind of midway through the procedure. So this would be a last resort. Metatarsalgia. So this, I put this in there just because I want people to think a little bit about the differential diagnosis. So this is where a patient comes in and says they have pain in the ball of their foot. And there's several things that can cause pain in the forefoot or ball of the foot that we see. And the most common probably is metatarsal phalangeal joint capsulitis or plantar plate issues. And in reality, as people age, just like our Achilles and our plantar fascia change, our joint capsules and ligaments, and there's a structure on the plantar aspect of the joint called the plantar plate, which is a really strong ligament that helps hold the toe in place. And then you have collateral ligaments on the medial and the lateral side. And as patients age, these tissues can break down and the toes can start getting deformed. They can pop up in the air, they can hurt, they can swell. And so this is one thing that can cause forefoot pain. Often it's pain on the bottom where patients will feel like they're walking on a marble or a ball. But it can also have pain on the top, and you can have swelling on the top of the foot. The other thing that causes pain in the forefoot between the toes is neuromas. And I find that neuromas, patients come in thinking they have a neuroma, but it's not the most common thing and often gets confused with MTP capsulitis or an early hammer toe formation. For a neuroma, the third web space is the most common place. And I think it has to do with the fact that the second and third metatarsal or tarsal metatarsal joints move similar. And the fourth and the fifth tarsal metatarsal joints move similar. But there's a big difference in the amount of motion between the third and the fourth tarsal metatarsal joints. And I think that has something to do with the increased motion between the two metatarsals relative to each other. May have something to do with why the nerve in the bursa gets irritated in the third web space much more than the fourth or the second or the first. If someone comes in and they say they have a neuroma, like in this picture, this patient thought she had a neuroma and it's causing her toes to spread. Almost always if someone says they have a second web space neuroma and their toes are spreading, it's usually not a neuroma. It's usually related to the MTP joint itself. The other thing we'll see in the forefoot that causes pain or swelling is a stress fracture at the metatarsal neck. And so someone curbsides you for forefoot pain or pain near the ball of the foot, these are the three things to think about. X-rays can be very helpful. So when you get the X-ray and you look at it, and when you examine them, the things we look for. So for a joint issue, for an MTP joint issue, for MTP capsulitis, we're looking for tenderness at the met head directly, mostly plantar, but it can be dorsal. You can actually do a drawer test where you shuck or you do a drawer plantar to dorsal on the MTP joint, and it will often elicit pain, or you can even appreciate some instability compared to the contralateral side. And then you'll see deformity. So on that last picture, you could see the toes spreading. And on the X-ray, you can see a subtle shift of the second MTP joint where the phalanx is starting to drift off the metatarsal head. And so that's not a neuroma pushing the toe out. That's failure of the joint capsule, plantar plate, or collateral ligaments. And then you're getting a deformity as a result. So for a neuroma on exam, it's a little bit different. The tenderness is usually in the web space, but not directly on the metatarsal head. So you have to be pretty picky on your exam. If you compress the metatarsals, it'll often hurt. You may feel a click. And so that can be consistent with a neuroma. Usually with metatarsal compression, early hammer toes or MTP, capsulitis, plantar plate issues usually are not as painful with metatarsal compression. If we want to diagnose a neuroma, you can't see it on the X-ray. So if the X-ray looks normal and you're really worried about a neuroma, you need to order an ultrasound, and that's very user dependent. Or if you're going to order an MRI with contrast is best. That's the best protocol to really see it. And a stress fracture you can usually see on an X-ray, if not the first visit. If they don't improve and you get an MRI, you may see significant bone marrow edema near one of the metatarsal necks. Treatment for metatarsalgia depends. So if you think the patient has more hammer toe abnormalities, joint capsulitis, then we're always going to check their gastroc, and we're going to make sure that they're not overloading their forefoot because they lack ankle motion when they stand. So sometimes stretching out the gastroc helps the ball of the foot. So it's a little bit of a leap of faith for the patients, but it's important to check and to have them do it. Shoe changes really help. There are different slides or tennis shoes that really do a nice job of unloading the ball of the foot. And so getting them in the right kind of shoe makes a really big difference. In our practice, we like Hoka, but there are other brands as well. And it's not like these patients have to wear this type of shoe forever. But while that joint is inflamed and the ball of the foot is inflamed, it's very helpful. Orthotics with or without a met pad can be very helpful. This is one of the cases where a custom orthotic may be helpful early on. It may be very important for two reasons. One, you really want to unload the metatarsal head, and the best way to do that is to have an orthotic with a high enough arch. And the other thing is if it's their second metatarsal, you really want to check their first ray and make sure that they're not hypermobile, because sometimes it has to do with their foot becoming flatter and they're overloading a different part of their foot. And so you want to just make sure that their first ray is not hypermobile, because it may change how you treat them. Walking boot can help calm it down. Surgery is a last resort. And when it comes to surgery, there's no perfect operation for a hammer toe or a joint capsulitis. So we try to get them better with conservative stuff first. For neuromas, the treatment's still similar. Corticosteroid injections can be helpful. You have to make sure not to use too much local and too much steroids so it doesn't splay out to the whole plantar aspect of the foot. Over time, I've limited my practice to where I only do 1 or 2 steroid injections. And the reason is if you do too many, I do think it affects the body's ability to heal if they ever have the neuroma resected. And if you get a wound after a neuroma surgery, it's a disaster. And so we try not to inject too much steroids into this area. You also want to make sure that someone actually has a neuroma before you do a corticosteroid injection. And the reason is if you think they have a second web space neuroma and you do a corticosteroid injection like you're treating a neuroma, and some of the steroid gets around the lateral collateral ligament, then they come back and see you a few weeks later and their toe's crooked, and they're very unhappy. And so what you don't want is to treat a neuroma that's actually an early hammer toe, and the steroid weakens the tissue and their hammer toe progresses. They won't be happy if you do that. Sclerosing therapy can help, where you use a series of alcohol injections to try to deaden the nerve or reduce pain. For neuromas, we recommend orthotics to help kind of splay the metatarsals apart, or wide toe box shoes. Excision can be helpful in the right patient, but the patient satisfaction is fair in the literature, and that may be because there's other abnormalities causing the patient's forefoot symptoms and not just the neuroma. Stress fractures are treated with immobilization, vitamin D, shoe changes, gastroc stretching, and then again, if they have a stress fracture on their second metatarsal, why'd they get it? Are they osteopenic, or do they have a hypermobile first ray and they're overloading the second? So in that patient, you wouldn't just want to treat them and get them better. You'd want to get them an orthotic in their shoe to help with the hypermobility. Let's go to fifth metatarsal fractures. This will be our last topic, last 10 minutes here. So fifth metatarsal fractures, again, these are super, super common. That's why I wanted to include it. Probably not as common as ankle sprains, but common. And same type of injury. Usually it's a twisting injury or inversion. Patients are usually younger or more active, but as patients get older, they can have a lower and lower energy mechanism of injury and have a fifth metatarsal fracture. In addition to examining their foot, you always want to check their ankle ligaments, because a lot of times they sprain the ankle and we get focused on treating the foot and we forget to rehab the ankle, and then they come back and see a foot and ankle provider later with chronic ankle instability or peroneal tendon pathology because we never recognize the ankle injury. So even if you see a foot fracture on an x-ray from an urgent care or something you pick up in your office, make sure you check the ankle. Very important. X-rays are helpful. The oblique X-ray always looks the worst compared to the AP and the lateral. Treatment for fifth metatarsal shaft neck fractures, almost always non-operative. There was a great study in 2013, 142 patients treated non-operative despite the position. Only 2 developed a painful non-union. If I'm going to fix them, it usually is because the fracture is so angulated where their fifth toe is going to cause a problem, or I feel like it's going to affect their weight bearing. But I don't treat these surgically just because they're displaced. They have to be significantly angulated. I normally prefer K-wires because I can take them out and there's no room issue with painful hardware. But once in a while, if it's really comminuted, the K-wire, I'm worried it won't hold, and we will use more formal OIF with plates or screws. Also, to remember, if you're following these with x-rays, patients typically feel better before their x-ray looks good. So they'll come back and see you and they'll say they're doing great and they're out of their walking boot at 8 weeks, and you'll take an x-ray and you'll see no bone healing. And so that's not uncommon with these. And if you just watch it and watch it and watch it, it will eventually heal with bone. And again, so I always remind the patients of that early on, that they're going to feel much better before their x-ray looks good. Typically a short walking boot or a tall boot for 4 to 6 weeks, and then transitioning to a hard sole shoe. Fifth metatarsal base fractures. There's different zones for fifth metatarsal base fractures, and we treat them slightly different in each way. There's the zone proximal to the articulation of the fifth metatarsal with the fourth metatarsal. There's the zone at the articulation between the fifth metatarsal and the fourth metatarsal. And then there's more of the diaphyseal fractures of the fifth metatarsal base. So there's 3 different regions and they're all treated differently. And that's because the blood supply to each area is different. The blood supply to the distal and most proximal zones is good, and the blood supply to the central zone may not be as good. And sometimes the fracture doesn't heal as predictably. So zone 1 fractures, which are more avulsion fractures off the base, they're called the pseudo-Jones fracture often. These are usually a twisting injury, and it's pull mostly from the lateral band of the plantar fascia, but the bigger the fragment, the more likely it may involve the peroneus brevis tendon. So again, this is usually an inversion injury. Just like metatarsal shaft fractures, we always want to do an ankle ligament exam and check their ankle. and look for a cavus foot or foot deformities. They're usually minimally displaced on the x-ray. And as kids are younger, you have to watch for an apophysis because it may fool you and look like a fracture. You can always x-ray the other foot and compare if needed. For zone 1 fractures, almost always treated non-operative. The only time we'll consider ORIF is if it's tenting the skin or significantly retracted and angulated, where we really think it's going to cause a problem. And the reason is they usually heal, and if they don't heal with bone and they get a fibrous union, they're usually asymptomatic. And there's a lot of good studies showing that even if someone gets an avulsion fracture, the fifth metatarsal base, and they return to see you in a year and it's bothering them, that you can just simply excise it and the recovery is very good. So these are typically treated non-surgical for that reason. Zone 2 fractures, so these are your Jones fractures. These are the ones where the blood supply is more tenuous and the fracture line is where the fifth metatarsal and fourth metatarsal articulate. These are almost always a twisting injury. Same thing, look for a cavus foot. That just means high arch because you're more prone to get this type of injury. Also check your ankle ligaments on exam. Fractures are not usually displaced here, and you have to look for signs of a chronic stress reaction. Like in this patient, you'll see a really thick lateral cortex. That means they've been overloading the metatarsal for a while before it actually cracked. How do we treat these? So these are different than avulsion fractures. We actually do sometimes consider surgery for these. And there's not a right answer. We consider age, health, hobbies. Is it the right foot? Is it the left foot? Did they injure it at work? Are they a pro athlete? Has there been prior pain or injuries? Those are all things that go into our decision-making with the patient. If you're going to treat it non-operatively, usually I cast them early on while they're in pain if they can't walk. The traditional thinking of using a cast for 6 weeks remaining non-weight bearing, I've gotten away from that, and many of my partners have as well, where we actually let them go to a boot earlier. And the main thing is if there is a non-union rate for these, nothing worse than being non-weight bearing for 6 weeks or 8 weeks, and then it's still not healing and starting over. So and I don't know that there's evidence that putting some weight on it early affects whether or not it unites. So we do usually let them go to a boot earlier if we treat them non-operative. And obviously we're going to treat an elderly zone 2 fracture different than a young athlete. Operative treatment for Jones fractures, so right foot, single parents, industrial injuries, athletes, someone with a high arch. These are all people that are higher risk for non-union or really need one episode of recovery and don't want to take a chance that it may not heal. And so we're a little bit more aggressive about fixing them with a screw in these patients. Zone 3 fractures are treated very similar to zone 2. However, they may be more chronic in nature. And so in some of those patients where they've had chronic pain and then it cracks, sometimes a screw can provide a more predictable result. All right, so there's the short summary on common foot and ankle things that people may curbside you on. Please feel free to contact me with any questions.